Okay, so far we've discussed the initial assessment and our approach to the care of any sick baby is we do evaluate, we identify, and then intervene. And these three partners are done within a block of time. And this block of time is usually 1 to 2 minutes in children and 30 seconds in newborn. So the first cycle was for initial assessment, and then we went to the primary assessment, and we said it's A, B, C, D, E. We already discussed A, the airway, and B, the breathing, and we stopped at the circulation. Do you guys have any question from the previous sessions? Any question, any comment, anything? Okay, so we dealt with A and B, and we started with the circulation. And who's the iPhone? We said we cannot accept a person without real name. I'm sorry, I won't accept the iPhone until he or she change her name or his name. So I'm gonna remove the iPhone, okay? I'm not gonna accept. So if you know who's iPhone 13 Pro Max, iPhone 13 Pro Max, they need to change their name. I won't allow them to enter. I'm sorry. So the circulation, how we assess the circulation is we assess the heart rate and the rhythm. We also check the pulses, peripheral and central. We check the capillary refill time. We check the skin color and temperature. We check the blood pressure, the urine output, and the level of consciousness. Now, we have more to add, but not in a routine care. In intensive care, we also check the near-infrared spectroscopy. If you kindly advise the iPhone 13 Pro Max to change their name before they come in. So also we add NIRS, and by the way, tomorrow we have session in the morning for Fujairah Hospital from Emirate about near-infrared spectroscopy, because they bought 10 machines and they don't know how to use it, so I'm training them how to use it. So if somebody wanted to attend, you're welcome. I think I inserted the link for the meeting on the group. Okay, so let's start one by one. And remember, it's a tripod. Evaluate, identify, intervene. So let's talk about the heart rate and the rhythm. So the heart rate range in pediatric between 75 and 140. Now, in a newborn, it's usually 120, and it ranges from okay, now this is correct. Okay. So, but it reaches up to 180 sometime and down to 120, so that's not a problem. And as the chronological age goes by, the heart rate goes down. And usually it reaches to the adult level around 75. Okay? Now, sometimes we have the rate is high, we have the rate is low. These are depend. So if you are athletes and you have good cardio and you practice everybody, like me, your rate, my current heart rate is 35 at rest. So your heart rate can goes down, and we call it bradycardia. but also hypoxia and hypoxic cardiomyopathy can cause. Okay. Hannah iPhone. Okay, please ask her to change her Hannah or Hannah iPhone. Please ask her to change her name to her full name. I'm not allowing her in. We have also we have causes of tachycardia, many. Fever, it can be sinus, it can be many conditions can cause tachycardia. All of you know what is tachycardia. Now, the importance here is increasing heart rate for cardiac diseases versus increasing heart rate for respiratory diseases. Now, here is the trick. You count both. So the more they are discrete, the more they are variant, the more they are away, it's cardiac. The more they get close, it's respiratory. Okay, so usually the heart diseases cause very high heart rate and not very high respiratory. So the difference between the respiratory rate and the heart rate, it becomes very wide. While in respiratory problem, the difference between the heart rate and the respiratory rate is not that high. Is that clear?
Yes.
Okay. Well, then I know I have to give you some tips today I've learned away from this session. First, do not use nebulizer. Nebulizer is not a good machine for asthma. I was surprised that you guys still use nebulizer. I never used nebulizer in the last 15 years. Okay, so please use inhaler with spacer. That's one. Second, in acute attack, we don't give inhaled steroid because steroid cause bronchospasm. Okay, so inhaled steroid is for prevention, not treatment of acute exacerbation. If there is acute exacerbation, you have to give steroid systemic. And it's been found that early use of steroid is one of the causes of decreased PICU admission for asthmatic patients. And you have to use CPAP as early as you can. So CPAP, systemic steroid, avoid inhaled steroid, give systemic steroid, and give inhaler, not nebulizer. Because the waste rate in nebulizer is more than 80%, and some of the nebulizer is 95%. Please ask Hannah iPhone to change her name. I'm gonna let her in this time, but please advise her to change her profile name to her full real name.
Okay, doctor, okay.
So it's very important to remember these when you treat. So go back to the session. As we said that the pulses can be measured peripheral and can be central. Okay, so central, usually we check it at the brachial, at the femoral, at the carotid, at the axillary. And it's important when you check in the carotid, you only check one side. In the peripheral, we check it at radial, at dorsalis pes, as posterior tibial. But please remember the peripheral vasoconstriction and vasomotor instability and environment effect on the peripheral pulses. Okay? And also ask Zina to put her full name. So Hannah, Zina, and iPhone Pro or something. Please ask them to put their full name when you enter the room. Okay? So once the heart rate become weak, it can stop. Remember that. Once it's below 60, remember it. Now, before we used to just mention the heart rate, and now we found that heart rate is not important as, and I will give you a session about smart monitoring, is human beings are variable. Human beings are never fixed. We move, whether emotion or vital signs or whatever. So we always have variability. So the beat to beat fluctuation is very important. So once you have beat to beat fluctuation are normal. But if the changes are sudden in the beat-to-beat variability, then remember the premature atrial contraction. And premature atrial contraction are very common in premature babies. They're so common. And most of the time, I don't do anything for them. While premature ventricular contraction, okay, they are also common, but not as common as premature atrial contraction. Now, pulsus paradoxus, where, the chest are a little bit inflated, press on the heart and changing the heart rate. Remember, they can cause pulsus paradoxus. What is pulsus paradoxus? Do you guys know? Anybody knows what's pulsus paradoxus? No answer? Anybody knows what is pulsus paradoxus?
I think it is decreasing in the blood pressure during inspiration.
Okay. Any other comment? You're not decreasing, but it's usually decrease, but exaggeration of the decrease. Okay? Normally it's less than 10 changes between before and after inhalation, changes in the blood pressure. It's usually less than 10 millimeter mercury. But if that exaggerated, then you have pulsus paradoxus. An example, whenever there is compression on the heart from inflated lung or filled pericardium that compromise the flexibility of the heart and causing the fluctuation for that reason. Okay? So remember, fluctuation is very important. And fluctuation also is important in blood pressure. Okay? So I will teach you how to diagnose whether you need to give Lasix or normal saline from the fluctuation of the blood pressure. Because if the fluctuation is more than 30% between systole and systole, between beat and beat, then probably your blood vessels is compressible and probably they will respond to normal saline bolus. But if the fluctuation is less than 30%, you probably should not give proper saline. You probably, your vascular system are already filled with fluid. So fluctuation are very, very important. And also I will teach you the smart monitoring later, how to know if the child in pain or your heart is okay. And also you look at autoregulation by looking at the beat-to-beat variability and how we do histogram and tachogram and point care, these type of monitoring that I will teach you at some point, what we call it smart monitoring. But pulsus paradoxus is, remember, is exaggeration of normal physiological process. Now, capillary refill also is a very good sign. So decrease if a capillary refill is prolonged more than 2 seconds, 3 seconds, 4 seconds, then probably your perfusion is not good. And remember, when you do it in a hand that should be above the heart. Okay? Now, if you look at the changes in the heart rate or changes in the blood pressure or changes in the capillary refill, all these, they call it blunted signs, which means they occur after the event. They occur when the changes in the heart become structural, while we can pick the problem before that through using near-infrared spectroscopy. So we can know if the heart will be compromised like 5 to 8 hours before these capillary and pulses change. And that's why near-infrared spectroscopy are important. And I will show you later, inshallah, when we took hemodynamics sessions and I teach you how to do echo and all these things in hemodynamics. When we took to the cardiovascular system, after we finished the acute care of sick baby and acute care of sick child and sick newborn, and also we took ventilation and sedation, we will go to hemodynamics. And in hemodynamics, you will learn more. But today, just a glimpse, just vague ideas. Any question? Okay. So it's very important to measure the cardiac output because it decreases in shock, and this result in decreased perfusion to the organs. Usually the decrease start with peripheral, then central. And usually it starts with less important organ to the serious organs. And remember, when there is cold temperature around the baby, so there is vasoconstriction, so the perfusion might mislead you. And now delay, sluggish, or prolonged capillary fill time. It's caused by many things such as dehydration, shock, hypothermia. Okay, but sometimes you have shock, such as warm shock, or you have shunt shock. For example, in PDA, you might have normal capillary refill time. Now it's a 5 categories of shock, and I will teach you one by one and how to treat and how to find it on echo and how to assess the right side function of the heart and left side function of the heart, how we look at the heart rate, how we look to the saturation, how we look to the tissue oxygenation, and so on. And you will feel, you will start to feel proud of yourself because you really understand what's going on and you really can help the person and you know what you're doing. So that's the fun part of understanding how to deal with sick babies. Skin colors and temperature, very important. Pallor. Pallor, P mean we're losing the ruby color. We are losing the pink color of the skin. So slowly the skin looks like deprived of blood. Okay, which means that the blood is actually not there. It can be because perfusion decreased. Okay, or sometimes it's because the vasoconstriction due to cold, and also stress release vasoconstriction inotropes and it cause vasospasm and also can cause pallor. But also there might be good perfusion, but the hemoglobin are diluted just in anemia. And remember that if the skin are pigmentation change, it might have a problem in diagnosing pallor. Remember that when you use it, check it in sunlight, not artificial light. Be familiar, and also you have to know the skin color of that person before you assess. Okay, remember also to look to the central pallor. Okay, and in central pallor you either look at the tank or look at the sclera at the palpebral fissure. Do you guys know what is palpebral fissure of the eye? Anybody knows? I always concentrate on these words because I know people never pay attention to them and they're very important. So anybody tell me if you know what is palpebral fissure. We always say palpebral fissure of the eye. What is palpebra of the eye? Anybody knows?
It's the movable skin over the eyeball.
The movable skin over the eyeball. Okay, any other idea? Who said?
It is the area between the eyelids, between two eyelids.
Who's talking? Who's talking?
Zina. Zina is talking.
Zina, okay. Okay. Any other idea?
It's an area between extending from lateral canthus to the medial, يعني outer to inner.
Okay. So palpebral fissure is the visible part of the eye. Palpebral fissure is the part of the eye that you can see. Is the part of the eye when the eye is open between upper and lower eyelid. I think the second doctor say it correct. But palpebral fissure is the part of the eye that you can see, and it includes the iris and the conjunctiva over the eyeball, because conjunctiva also below in the lining, the inner lining of the upper and lower eyelid is also conjunctiva. And palpebral conjunctiva is the conjunctiva covering the eyeball around the iris. So when you look to the palpebral fissure, there is a blood vessels. And usually when you're pale, you don't see these blood vessels. Okay, especially if you are dark skin and it's hard to see the pale, then that's a good idea to check that. Now, mottling is a mesh-like discoloration of the skin. So some area of the skin are hyperemic and the other are oligemic. So you'll see pale and redness and you look like mesh-like. It's like the mesh that protect the window from the insects. So it's a mesh-like presentation and it's a kind of vasomotor instability due to hypoxia, hypovolemia, shock, or irregulated vasoconstriction. Cyanosis, remember we said central and peripheral, and there are acrocyanosis in a newborn. We said it's at least 5 gram we're losing, and it's if the 5 gram, it's standard hemoglobin 14 or 13, it's around 30%. Mean saturation will be 70 before the cyanosis occur, and that's too late. Okay. Now also cyanosis can occur in when you are on the higher level, on the sea level, and you get less oxygen, so you get high altitude. Okay, in traumatic brain injury, you can also get carboxyhemoglobin. It can be also occur in drug overdose, pneumonia, asthma, adult respiratory distress syndrome, and cyanotic congenital heart disease. Also, skin color and temperature, we check the pallor, we check the mottling, the cyanosis, and now the temperature. When you check the temperature, you always check it in the bag of the hand, okay? So you slide your hand, okay, and usually start from the cold and move it to the warm part of the body, and always compare both sides. Okay, and always compare both sides, okay? So remember, we've talked about circulation, we talked about heart rate and rhythm, we talked about the pulse, peripheral and central, and then we talked about capillary refill, and then we talked about skin color and temperature. So that's our evaluation. And now we check the blood pressure. Now, before we used to measure blood pressure and give us the systole, the diastole, and the mean. Now, when I was trained like 20 years ago, I used to have an equation, okay? And then with time, we moved to the centile. Now we check the centile. Now, even the centile are not correct. So now we go to smart monitoring. And I will teach you how to smart monitor the blood pressure. But the blood pressure are two types, the invasive and non-invasive. And remember that there are two types of measuring blood pressure. There is the oscillometer, and there is the Kartukov sound, the sphygmomanometer. Okay, so they are a little bit different. Because the oscillometer use something called PTT, pulse transit time. I don't know if you guys know that. And the sphygmomanometer use the sound, the Korsakoff sound. So remember that when you check the blood pressure by machine, it's a little bit different when you check the blood pressure by the mercury, use the Korsakoff sound. So please make sure that you understand. So this is the peripheral, but also we have the invasive blood pressure monitor. Now, there's also systole and diastole. And people I used when I was trained in 2010, we used to use the mean. And then we discovered that the mean is nothing but 2/3 of systole and 1/3 of 2/3 of diastole and 1/3 of diastole. So it's just a number to make your life easy, but it's actually misleading you. So usually when I ask a blood pressure, but also I ask for systole and diastole, and I ask by pulse pressure rather than the mean, because actually the pulse pressure that gives me a lot of ideas and type of shock rather than the mean. So please remember these facts: the oscillometer, blood pressure measurement used by machine, the sphygmomanometer, and the mercury using cuff, and using the Korsakoff sound. So the Korsakoff sound are more accurate than oscillometer, because the oscillometer use something, pulse transit time. So the pulse transit time is measuring the do you know what's PPG? No, I don't. No, I'm not going to go to these details right now. I don't think you will know. I will teach you that later on. So please, when you measure the blood pressure, use the mid-arm circumference, and it should be 40% of the mid-arm size, and also it should be 50 to 75% of the length of the upper arm. Now, not all the time you will find, but the more than you should realize that your measurement might be wrong. However, even if it's wrong, the trend is not wrong. So let's assume, who's with me right now? Let's ask one person. Okay, so let's assume that Aram is measuring a blood pressure. And Aram measured blood pressure, and he opted a wrong cuff. And he measured the blood pressure, and he got a number. And the cuff is a little bit higher than the size of the recommended size of the cuff is higher than the actual size of the arm. And then he got, because it's a big, he will get small numbers. So they're wrong. They're not really reflecting the actuality. However, when Aram checked the blood pressure again, it's the same error. And then again, it's the same error. So if he got these three numbers, their trend is not wrong. Okay? So it's very important to remember that if you keep measuring the blood pressure, like you measure it by the for example, by the cardiorespiratory monitor, and you put in the monitor, measure the blood pressure every 15 minutes, after 12 hours, you get like 36 reading. And then if you plot it, you'll see that the variability. You remember the variability? And you'll see the systole and diastole, and you'll see the variability of pulse pressure, which is the difference between systole and diastole. So it's very important that we look to the trend and smartly monitor the blood pressure rather than looking to one number. Now, decrease blood pressure if you have hypotensive, dehydrated, bleeding. Remember, when usually when you are hypotensive, your heart rate goes up. But if you are hypotensive and your heart rate is low, then you probably terminal, a very ominous sign. Is that clear? Do you guys have any question? Question?
It's clear,
Okay.
dear doctor.
Okay, so these are some numbers, and please don't depend on that, because most of the time I don't look to the number, I look to the trend, and I will teach you how we diagnose shock when we look to these numbers. Okay, these numbers are good for hypertensive maybe, but is not good for hypotension. Okay, so these are to make your life easy and to organize your work. So if you are 1 month and you are less than 60 systolic, then you have a problem. If you are first 12 months less than 70, you have a problem. And then if you are 1 to 10 years, so just please take 70 and then double the age and add it to the 70. And if you are between 1 and 10 and you are less than that number, then you probably have a problem. If you are more than 10 years and you are less 90, then probably you have a problem. But if you already measure the blood pressure and it's less than 10% of your previous, then probably check yourself about your trend, and you might have circulation problem. Okay? Please remember to check the urine output, ml per kg per hour, and look at the level of consciousness. Okay, so now we did airway, breathing, circulation, and now we will look to the D, or disability. And remember, we did our initial assessment, and now we are in our primary assessment. Now, disability, we're looking to the nervous system. And we're actually assessing the hemodynamics, but from the brain point of view, from the master of the body, okay? So because when you have circulation problem, blood and oxygen is not going to the brain. And remember, the brain needs constant supply of sugar and oxygen. So whenever you have a problem with the sugar or you have a problem with the oxygen, the brain stops working. And I'm sure you guys have seen when you get hypoglycemia, you get headache, you get some tremor, you get weakness, you get some blurred, and then you reach to a place when you start to have something like psychosis. So you start to say F word and you can be violent until you lose your consciousness. So it's very important to remember that brain need oxygen and sugar always. And whenever the oxygen decrease, whether it's because of decreased carboxyhemoglobin or decreased perfusion, both change the function of the brain. So when we say disability, we're actually assessing the circulation or the dynamic function rather than we're talking about the brain itself. Okay, so how we assess the neurological sign of circulatory problem, or another way, cerebral hypoxia? Oh, I remember very important things that, and I hope that you teach your colleagues now. When I just remembered, since I came to Erbil, I always hear عند نقص أكسجين. سامعين بها الموضوع؟ Anybody
Yes,
heard that
Naveen.
when the patient comes نقص أكسجين؟
بلى.
سامعين بيه؟ There is no term in medicine called نقص oxygen. Okay, that's one. Second, نقص oxygen cannot be diagnosed by MRI. That is incorrect. Okay? If we're talking about HIE, hypoxic ischemic encephalopathy, it only can be diagnosed by MRI between day 4 and day 7. On day 8, we cannot diagnose it. You lose the opportunity. Okay? And نقص oxygen is by history, not by radiology. So let me give you an example. So let's talk about one of you. Let's talk about Sirwa. Sirwa is here? Sirwa? Sirwa Muhsin? Sirwa is here?
Yes,
No?
doctor, I'm here.
Okay. So Sirwa, do you have a car?
Yes.
Okay. So let's assume I came to your car and then I start to check your car. And I told you, oh, there is accident here. How? I said, well, I have a machine. I have MRI. I can see accident. And then you told me, but doctor, I never had accident before. Okay?
Okay.
Do you understand?
Yes.
Yeah, so that's exactly what happened. They come to me and they say, okay, عنده نقص oxygen. شلون? By MRI. بس هو صار عنده نقص oxygen? Is there a history? They said no. Do you understand? So نقص oxygen or hypoxic ischemic is by history, not by radiology, because increased intensity affected the watershed area. Do you guys know what is watershed area? Anybody knows what is watershed area? Okay, the watershed area is when the external blood supply of the brain, okay, meet the internal blood supply. So we have two types of supply of the brain. There is from the outside and from the inside. So they meet at a point in the middle. So when you get hypoxia, obviously that area will be affected. Okay, so the first area affected is the basal ganglia, and sometimes the internal capsule, and then it goes to the hypothalamus and maybe the midbrain. Okay, hypoxia will never affect the cerebrum, the cerebellum and the cerebrum. So please be careful when you say, oh, عند نقص oxygen شلون by MRI. That is incorrect. So MRI will tell you that increased intensity and there is some damage or some injury happened previously. Now, what is the cause of this injury? We don't know most of the time. Okay? And remember, MRI after day 7, it cannot diagnose hypoxic ischemic injury. And then when we will take the HIE and cooling therapy and how we treat HIE, we will talk about this in details when we should do the MRI. Now, the MRI after day 7 will show you the gross abnormality. It will not show you the, and when you lose this opportunity, you see the flare, it cannot tell you that there was an ischemic changes. Is that clear? Is that
Yes,
clear? Anybody
yes.
have a question
Yes.
about this disability? Okay. So please remember, don't tell the patient عندك نقص oxygen if you don't have history of نقص oxygen. And how you know if the baby was giving to his mom right away. So please, it might be a degenerative brain disease. It might be a structural problem. It might be a congenital problem. It might be inborn error of metabolism. It might be idiopathic problem. Okay? It is not نقص oxygen. So please don't deceive the patient, because that's really deceiving the patient. And you know, I don't know how to say it, but just be careful what you say. Okay, you cannot tell that your car has accident and there was no accident. So it's very important to remember this, please. Okay, don't tell the person that from MRI عندك نقص oxygen. Okay, but you can say that there is injury, or there is some darar, some problem happened, but we don't know why, because they will go back to the obstetrician and they thought the physician did the problem. Because it's very important to remember these. Okay, so neurological signs of cerebral hypoxia is change level of consciousness, change in muscle tone, change in pupil response, and you might have seizure. There are subtle signs of them, such as confusion, irritability, lethargy, and agitation. So I'm not going to go and tell you what is the term, and I'm expecting that each one of you will go and Google what is confusion is, what is irritability is, what is lethargy is, and what is agitation. Okay? So please do not assume that you know these cases by heart. So please go and Google it, because I don't have time. I don't spend more time. Now you understand me. I will never pass a word that I don't know the meaning, and I don't assume that I know the meaning. Okay, so I'm expecting each one of you go today and check what is confusion, what is irritability, medical confusion, medical irritability, what is lethargy, and what is agitation. So next session, I'm going to ask each one of you what are these words. So I'm expecting that when we say muscle tone, you guys know what is tone, and when we say confusion, you guys know what is medical confusion is. So the first neurological signs, we said we have the subtle sign, but also we have a means, we have a protocol, we have a tool to assess the disability. We have something called AVBU. Okay, so AVBU is the alertness. V stand for verbal response, B stand for pain response, and U is for unresponsive. Okay, so it's very important that use AVBU instead of GCS, Glasgow Coma Scale. Okay, and Glasgow Coma Scale are a scale of out of 15. So if you are somewhere between 13 to 15, you're probably conscious and alert. If you are moderate, you're probably confused. And if you are severe, you're probably unconscious. And the Glasgow composed of 4 signs of the eye, 4 response in the eye, and 5 response of the verbal, and 6 response of the motor. So in total, it's 15. And also we have abbreviation called PIRL. And PIRL stands for pupil equally reactive to light. So when you say PIRL, that means we know that the pupil are equally reactive to light. When we say AVBU, then we know that the person is alert, the person have a verbal response, the person is responding to pain, and he's or he's unresponsive. So remember that you say he's alert. He has verbal response and he responds to pain. Okay, or he is unresponsive. Or use the formal Glasgow Coma Scale and remember the Pearl. Okay, so so remember this is our evaluation. Then yes, Hauraz, you have a question, go ahead.
Thank you very much. Dear doctor, regarding AFPO, can be calculated on 4 degree. It means alert, if fully alert 4, verbal response 3.
Yeah, so AFBO is a kind of a name to remind you how to do the disability. So remember, A, is he alert? Okay. Is he
Okay.
respond to verbal and asking his name or his whatever? He's responding to verbal. He has a verbal response. So he responding to language. Pain is when does he able to localize to respond to pain, like localize or by verbals, or he's unresponsive. So that's very quick to do it. If you don't want, you can do full Glasgow Coma Scale. Is that your question?
Score can be calculated or not by AFPO.
Which one? The AFBO?
Yeah.
No, there is no numbers. There is no score in AFBO.
Yeah. Okay.
It's just like an acronym to help you to remember how to do the disability. But there is no actual score of the AFBO. There is formal Glasgow Coma Scale. There is a score.
Okay. Yani if the patient in pain not respond to pain, it means less than 8. If we compare to
You probably, but AFBO you don't need to score. So you tell me he's alert. Okay, no, he's irritable. No, he is unconscious. Or he is responding to language. When I say his name, he responded. And he can localize pain, or he cannot localize. So it's just a reminder how and about the part of disability check. But if you want to do full, you do Glasgow Coma Scale, and it composes of 15. So you have 4 to the eye and 5 to the verbal and 6 to the motor.
Thank you very much.
Okay, and Pearl remind you how to say or express the status of the pupil. So you say pupil equally reacted to light, Pearl. Now, this is the identification. Okay, this is the evaluation. Then you have to identify. So you identify decrease consciousness. Now you have to think of the causes, and there are many: poor cerebral perfusion, or traumatic brain injury, or encephalitis, or meningitis, or hypoglycemia, or drug, or hypoxia, or hypercarbia. All can cause even hypocarbia also can cause, because hypocarbia decrease perfusion. So it's important to remember when your blood gas low, you should not be happy, okay? Because sometimes I come to the unit and I found the PCO2 is 18 or 20 and nothing has been done to the baby. So it's very important to remember not only hypercarbia cause change of level consciousness, but also hypocarbia. Now, whenever you have decreased level of consciousness, you right away go to the oxygen. Okay, how much oxygen you're giving and what's your saturation. And right away look to your ventilation. If you have transcutaneous CO2 or you have end-tidal CO2, and if you don't, you need to check the blood gas. And look at your perfusion. And if you have nerves, look at the cerebral oxygenation, if you have nerves. But if you don't, then probably you have to look for your gas. Okay, what's the time? So you have like 15 more minutes, so before we stop. And then at the end, so we did A, B, C, and D, and now E. And E mean exposure. Okay, so first, when you check a baby who is not responding or suck or crushed or very sick, you need to unaddress that baby and assess the face, the front, the back, the extremities, and the skin. You always maintain the C-spine. Remember to check the cervical spine. Always put the baby, if he's irritable, in a comfortable position, whether in his mother lap or you always use a blanket. When you cover the baby, don't use his dress or her dress. It should be unaddressed. Look at the evidence of trauma, bleed, burn, fracture, bruises, non-accidental, petechiae, purpura. So it's very important to check the exposure of the baby. And remember our cycle? Do you guys remember it now?
Yes, yes.
Yes.
Yeah, evaluate. We have the
Identify.
initial assessment, then we have a primary assessment, we have secondary assessment, diagnostic test. So our primary assessment, we identify the airway, the breathing, the circulation, the disability, and exposure. So remember that the airway, is it maintainable, non-maintainable, or obstructed? Breathing, do you have apnea or increased work of breathing, or we have a bradypnea? Circulation, okay, look at the pulses, the poor perfusion, hypotension, and bradycardia. Disability, level of consciousness, whether change or unresponsive. Exposure, very important. To expose the baby and look if the baby is under hyper or hypothermia, any trauma, any poisoning. Put the baby in a comfortable position. Please make sure that the baby is in a C-spine is important. Look at the sign of petechiae. Now, I want to tell you something. One day I was in the hospital in Baghdad, okay? And they were presenting a case. Of course, most people don't like me because of this, because I say my opinion right away. So they were presenting a baby who's 3 weeks, who came from Umara, and he got abdominal distension and vomiting. So 3 weeks, abdominal distension and vomiting. What is the diagnosis? What is the most likely diagnosis? 3 weeks, poor feeding, vomiting, abdominal distension.
Neck. Neck.
Yes, but what's more common than neck? Very common. You see it every day. Vomiting, decreased activity, poor feeding, abdominal
Sepsis.
distension.
Sepsis.
Sepsis, and then anything else. Right? Right? Or I'm wrong?
Yes.
Yeah, so sepsis. Okay. So this baby, they did CT scan of the abdomen. Oh. أنا صفنت من قالوا لي CT scan. Okay. And CT scan show adrenal hemorrhage. Oh, my goodness. And then they said neuroblastoma. My goodness. أنا يعني صورت نفسي غبي يعني ما بفهم. اوكي وين البيبي؟ حولوه من العماره الى المستشفى ببغداد. يعيدوا له الام ار اي او يعيدوا له السي تي. طلع ما بي شيء، ماكو عنده لا هاي ولا هاي. اوكي بعدين حطوا لنا صوره باتيكي. بعدين الدكتور كاتب باربرا فولمينانس. اوكي وين البيبي؟ البيبي مات. اوكي دكتور يعني هاي باربرا فولمينانس انا شايفها مره واحده بحياتي. هذا البيبي وين البيبي؟ وين البلاد جاز؟ وين اللاكتيت؟ What is the blood pressure? What is the blood gas? Where is the lactate? What is the antibiotics? What is the blood culture? What happened to the baby? نزلتها من الستيج. انزل دكتور انت fourth year وتقول هالكلام هذا؟ Purpura fulminans? This is sepsis. Okay, why didn't the blood gas? He said ما عندنا. Okay, you have to say that I should do blood gas, but I don't have it. You just don't jump it. Don't assume that, right? So please be careful. Because this is particularly remind me of that story. Anyhow, okay, so that's our identification, and then you intervene. So you have the identification on the left, and then you have the evaluation on the left, identification on the right on the table, and then you intervene. And remember to activate emergency code. And if you don't have code, you have to call for help. Okay, so you can shout. Life-threatening condition, or I'm uncertain of something wrong. Okay? Once you did the primary assessment, you go to the secondary assessment. Okay? Should I stop here? Right? Should I stop? Better to stop here, right? and I'll take some question, and then we'll start from here next time. Okay?
Okay, okay, doctor.
And I will stop sharing. I will stop recording too, so I can take question. Okay, so I'll stop recording.